Friends, good morning. My name is Dr. Vikash Agarwal. I am a senior consultant neurologist, an epileptologist, and epilepsy specialist working at Gleneagles Global Health City in Chennai, Pharmaco. I am involved with a lot of epilepsy work and pre-surgical evaluation and evaluation of difficult or drug-resistant epilepsies. I'm also involved with stereo EEG and other kind of advanced epilepsy comprehensive care. So to begin with, we have to understand that epilepsy is a very burning problem in our country. And if you see in a study in Kerala, the point or the prevalence of active epilepsy in our country is almost like 4.7 per thousand population. And there are different factors which decides the prevalence of epilepsy. And these factors are different when we compare urban versus rural population. For example, in urban population, there may be more of vascular risk factors or symptomatic epilepsy cases, or more factors related to tumors. Whereas in a rural population, we see more of infections like neurocystic sarcosis and brain calcifications due to neurocystic sarcosis or tuberculosis causing epilepsies or structural epilepsies. So there is a huge variation, but in general, if we see, the prevalence is somewhere around 5 to 10 per thousand population. Now, being such a common condition, and every physician or a neurologist is encountered with this problem time and again, and to give a better care of the patient, in this educational video, I'm going to talk a little bit about very basics of epilepsy, when a person should be referred for a second level tertiary care, and when a person with epilepsy should be referred for a tertiary level evaluation, like for a stereo EEG or for further evaluation for surgeries like VNS or deep brain stimulation. So to begin with, there are two types of epilepsies in general. So from time and again, the International League Against Epilepsy has classified epilepsy into different types, and the epilepsy classification has been taken a sea change when in 2017 they came up with a newer terminology based on the previous classification. And this ILA classification had inputs from all over the world. So the classification and the modifications by the task force were proposed, and subsequently to that, after several inputs from people with epilepsy, epilepsy groups, epileptologists, physicians, then they came up with something which is a policy from the International League Against Epilepsy. So it has been a very democratic process in this classification. So in this particular classification, it has been said that what we used to call it as partial epilepsy, or epilepsy which starts from a spot or a point in the brain, better to call it as a focal epilepsy. So in this focal epilepsy, a person with epilepsy can have a retained consciousness, or the person may lose consciousness. What we call it as focal epilepsy with impaired awareness, or focal epilepsy with retained awareness. As opposed to another condition of generalized epilepsy, where which we used to call earlier as idiopathic generalized epilepsy, better to call it as a genetic generalized epilepsy, or GGE, where even if it is starting from one single point in the brain, the epileptogenic foci is quickly recruiting several circuits in both the brain hemispheres, causing the person to fall down and have a very big major fit or generalized epilepsy, or what was previously told as grand mal seizures. Now, having understood this difference in the two basic types of epilepsy, whether a focal epilepsy or a generalized epilepsy, we need to understand that large group of patients are structural or symptomatic epilepsies, which means that there is a change or a problem in the brain circuitry or in the structure which causes this particular kind of epilepsies, either basically a focal epilepsy. So in this regard, it is very important to understand the etiological factors in our country. And I think in our country, the most important etiological factors is infection, like neurocystic sarcosis or tuberculosis, which is maybe responsible for a large group of patients with epilepsy. Now, when we start treating a patients with epilepsy, almost 70% of the people they will get what we call it as epilepsy resolved. We don't call it as epilepsy in remission now, we call it as epilepsy resolved. And so 70% of them will ultimately were candidate where after a few years or after a definite period of time when there is no seizures, we can withdraw medicine. We'll talk about that a bit later. But among these patients, there may be some 30% of the patients who turn into a drug refractory epilepsy. So there has been a very famous definition of drug refractory epilepsy, which means that in spite of using two appropriate and adequate drug for an adequate period of time, if the epilepsy is not under control, we call it as a drug refractory epilepsy. Now, how to understand this concept of drug refractory epilepsy? With the advent of newer and newer AEDs, it has understood that even if we add newer anti-epileptic medication, which we now call it as anti-seizure medication, this differences in the controlled epilepsies or epilepsies in remission versus drug refractory epilepsy has not come down. It has almost stayed 70% versus 30%. But still, there is a lot of hope now for these drug refractory epilepsies or DRE patients whom with various modalities of treatment we can give better care and maybe help them to live a more better quality of life. Our goal is not to treat the patient alone, epilepsy alone, but our goal should be to have a patient-centric care in which we should be able to give them a better quality of life, considering several factors which are associated. Not only the medications factor, but we should also consider the cost involved of the treatment, what we call it as Pharmaco Economics, the social factors, the caregiver factors, and the community approach or the community attitude towards the problem also in general. Now, how to decide which medicines to choose for a particular patient? This largely depends on the type of epilepsy which you are dealing with. So if we, as I discussed previously, if we are talking about focal epilepsies, then we usually start with oxcarbazepine or maybe also levetiracetam may be a good choice, or clobazam. By and large, oxcarbazepine or carbamazepine has been a first-line treatment for focal epilepsies. But with the advent of newer anti-epileptic drugs like lacosamide, we are using more number of patients as a monotherapy for these newer medications. The only reason is not that they are more effective, the effectiveness is the same. The only reason is that they may be much more safer in terms of their side effect profile and in terms of their interactions with the other medications. Many times in senior age group population, when they develop epilepsy, they may be on several other medications. So these newer medications are useful in these patients because there will be very minimal or almost nil drug-drug interaction. So the one important point to remember is that the choice of the medication depends on the type of epilepsy. Then let us come to other aspect of the choice of medication. One of the very important aspect is pharmacoeconomics. In the previous generations and even today, we use a lot of patients who are not affordable, especially in rural population, and patients who are getting care from our government setup clinics or primary health centers with phenytoin, which is a very cheap and a good drug. But there are definite side effect profiles with this medication. So we cannot advise a costly drug to a not so affordable patient because he's not going to take it. If there is a poor drug compliance from the patient, the epilepsy will not get controlled. And such patients can be labeled as pseudo-refractory. But in fact, they are not very compliant with the medication. So 1 month they may be taking medications regularly, the seizures are under control, whereas another month when they don't have much resources to take the medication, they stop the medication and they get the seizures. So this cycle may keep on repeating, so leading to something what we call it as a pseudo-refractory epilepsy. So once we have ruled out all these patients of pseudo-refractory epilepsy and we have ruled out all these patients of pseudo-refractory epilepsy and the patients which we consider as proper candidates for pre-surgical evaluation and whom after treating with two different drugs for an appropriate period of time are not responsive to medications, we take them for, usually we advise them a pre-surgical evaluation. So now we can venture into the field of pre-surgical evaluation for drug refractory epilepsy. What is this pre-surgical evaluation? This whole exercise, it's an important scientific exercise which an epilepsy specialist or an epileptologist takes with his patients, which involves several steps. Number one, namely, the basic step is to do a video EEG. Now, in a video EEG, it is an in-hospital setup where the patient gets admitted and goes through a EEG setup, a continuous EEG telemetry, along with the recording of his seizures by a camera. Now, in a controlled environment, we usually stop the medications and we allow the seizures to come out and express themselves. And then we try to understand the milieu of each seizure and try to understand from which part of the brain the particular epilepsy is coming. Once we can determine with the video EEG what is the type of epilepsy. Many times in video EEG, and there has been studies, especially one of my friend Dr. Neeraj Bhati has done it, that in fact many times what we consider as epilepsy and a refractory epilepsy may be in fact a non-epileptic phenomena due to depression or somatization, or what we call it as somatization disorders. So in this way also, video EEG can help us to differentiate, to accurately pinpoint the diagnosis of epilepsy. So once we do the video EEG recording, after the video EEG recording, we try to understand and see from which spot the epilepsy is coming. This is usually followed by a very good quality MRI of the brain and a PET scan. So taking these three information, video EEG data, the MRI data, a good quality MRI epilepsy study data, and the PET data, many cases we are able to pinpoint and localize that the epilepsy is coming from a particular spot. Namely, for example, one of the best situation is a condition called as mesial temporal lobe sclerosis, which causes temporal lobe epilepsy, which is one of the very prominent and very robust surgical substrate. And in fact, the initial studies which proved that the epilepsy surgery is useful and better than medical treatment in drug refractory epilepsies was done for temporal lobe epilepsy. So once we can locate very correctly and we have proved that the person is suffering from a true epilepsy and a true drug resistant epilepsy, we can offer them surgical treatments. Like under a surgical microscope, we are able to remove that particular spot which is generating the epilepsy. But provided we have to see that it should not cause any functional damage to the nearby structures or towards the function of the patient. This is more commonly seen when we are talking about epilepsies which arise from the dominant hemisphere or left side of the brain, namely functions like speech or our motor functions like our hand movements, hand grip. All these we have to carefully study so that they are not affected after the epilepsy surgery. In a very properly done center, these are usually not the problem because the epileptologist and the surgeon is very, very careful about these complications which can happen. So one should not refrain himself from going for a pre-surgical evaluation for drug refractory epilepsy, thinking that epilepsy surgery will lead to a further functional deficit or a speech problem or a weakness. So that is one thing. It's a very important message which I want to give it to all my friends by this educational video. Now, in spite of all this exercise in the pre-surgical evaluation, sometimes we are unable to localize or pinpoint that epilepsy focus, or what we call it as an epileptogenic area. In those cases, we may need to go for a level 3 evaluation, which is called as an invasive EEG monitoring. Now, what is this invasive EEG monitoring? There are two types mainly of this. One is the stereo EEG, another is grid or strip based invasive monitoring. So both has got their advantages and disadvantages, but to make it simple, basically instead of recording the electroencephalogram or EEG from the surface of the scalp, we put electrodes inside the brain by doing a first stage surgery. So it is a two-stage procedure. Where we implant the electrodes depends on the previous data what we have seen in the video EEG and the PET scan data or the MRI data. Based on these, we can further define the areas where we are putting the electrodes inside the brain. And then again, the patient has to undergo the same video EEG procedure where we are in a much better position to localize the area from where the epilepsy is coming. So after this extensive laborious task of stereo EEG or an invasive monitoring, more than 70% or 80% of the time, we are able to correctly say that where the epilepsy is coming from and offer a patient second stage surgery, which may be a definitive surgery. One has to understand that epilepsy surgery is not a cure, and there are failures of epilepsy surgery. This is more commonly seen mainly in the extratemporal epilepsy surgeries, and where the epilepsy surgeries are associated with the frontal lobe dysplasias, where the refractoriness or the surgical failure rates can be high. The main reason for a failure of an epilepsy surgery is incomplete resection of the epileptogenic tissue. Now, why there is an incomplete resection? One may be because it was not properly mapped, or second may be the reason that the epileptogenic tissue is coming from some of a functional area where surgery is not possible. But still, in many of these cases, the number of seizures or the epilepsy load or the seizure score comes down after the surgery, and ultimately we are able to offer a good quality life to the patient. Now, there is another group of conditions, which is my last part of my talk, and these group of patients, usually they are not amenable for any kind of pre-surgical evaluation, which means that after evaluation and after doing an extensive pre-surgical evaluation, we find that the epilepsies is coming from not one spot in the brain, but multiple spots in the brain. So which means that no focal surgery or a one-spot resection by a microscope, that surgical resection can be done for these patients. So what is the hope for this patient? Drugs are not working. We cannot go for a focal resective surgery in these patients. For these group of patients, and especially in children, there is a condition called as Lenox Costa syndrome, which actually fits in this particular condition. We can offer them other palliative procedures. So in our center, we have there are two different kind of palliative procedures. One is the callosotomy, and second, which basically prevents the falls in these patients, and second procedure is a vagal nerve stimulation. So now vagal nerve stimulation, which is a very old technique in the West, is being offered in our country at many centers, not only in our centers, but at many centers there, and it helps patients on a variable basis. So we cannot be very sure that after a VNS implantation, which is like a pacemaker, the patient will become seizure free. The results can vary from maybe no improvement to up to 80 to 90% improvement. So it's a very variable thing. Third and most important thing also for a palliative surgery is deep brain stimulation. So now deep brain stimulation, and I am a DBS expert because I see a lot of Parkinson's patient, and I'm a trained movement disorder specialist also, apart from an epilepsy specialist, because I have a fellowship in movement disorders also. So I do a lot of DBS for my Parkinson patient. The same deep brain stimulation or the brain pacemaker, which is nothing but a neuromodulation for the brain, by giving some electrodes, putting a permanent electrode in the brain and stimulating the brain with smaller degrees of current. Now this deep brain stimulation can be used for certain epilepsies, especially for refractory generalized epilepsy syndromes, and the target which usually is recommended is anterior nucleus of the thalamus. So anterior nucleus of thalamus is definitely very useful for DBS surgery for epilepsy. There are several other targets also, but it has been proven time and again that anterior nucleus of thalamus is one of the preferred site for DBS surgeries. But the problem with the palliative surgery is either a VNS or a DBS, they are quite expensive. Even the stereo EEG, which I discussed about the invasive monitoring, that two-stage procedure, that is also quite expensive. In a routine setup, it may cost somewhere between 10 to 12 lakhs. Whereas if from the first stage evaluation also, the patient can be offered a surgery that can be finished within 3 to 4 lakhs maximum. So it all depends, as you can understand, that all depends on the type of the surgery and the type of the procedure and the type of epilepsy. But there is a hope for every epilepsy patients in modern medicine, with a goal from every epileptologist or a physician that the idea should be to improve the quality of life. If we don't feel that this particular thing is going to help the patient, as a physician and as a doctor, as a human being, we should not, one should not offer those kind of treatments to that particular patient. So the era is of a precision medicine, but the era is also of a patient-centric medicine. We have to understand as a doctor that patient-centric medicine and patient-based goals are more important than academic or patient-based theoretical goals. So with that short note, I would like to finish my talk, and thank you for giving me this opportunity to produce this educational video, which may shed some light on epilepsy and epilepsy evaluation, refractory epilepsy, and how to go ahead with the refractory investigations. Thank you so much.